Thank you. So tonight I'm going to talk about another rare disorder, a group of rare disorders called lysosomal storage disorders. And this is similar to the last group of disorders we have, the peroxisomal disorders, in that they're progressive multisystemic disorders. We do have some treatments that are available, and I'll be talking about that a little bit. So this is Brian Madaud, and Brian Madaud has a disorder called Hunter disease. This is called mucopolysaccharidosis type 2. And in November 2017, he became the first human to have his genes edited. So this is pretty exciting. This is a novel therapy, and this is the second time we're talking about paradigm shift tonight. We're really moving into a new space, a new way of approaching these diseases. The treatment comes from knowledge, and that's what we're here for. We're here to learn about what we can do to improve the treatment for these patients and improve the outcomes that we get through this treatment. This occurred by zinc finger-mediated genome editing, and if we think about it, what we're basically doing is using sort of a find and replace that we would see on our Word. We're looking for that defective gene, we're picking it out and replacing it with a working gene so we can restore the normal function of that gene and the gene product. So what we're going to talk about is a little bit about the basics, because in order to understand how we go about treating these disorders, we need to understand what is the pathophysiology. And if we look at lysosomal function, basically what we're having is like a Roomba that is going around and cleaning up the debris in your cell. Now this needs to happen because what we need to do is we need to recycle and reuse. And in a lysosome, we gather up all this debris, and it's brought by the autophagosome to the lysosome where these products are broken down so they can be recycled. If we have a problem with one of the enzymes that is involved in this process, we get a buildup of some of the specific substances, and that can cause damage to the cell. I'm going to be talking about the mucopolysaccharidoses, and this is a group of lysosomal storage disorders. And when we speak about lysosomal storage disorders, they are quite rare. A lot of the diseases that I follow, there might be 10 cases in Canada, or we might have a more frequent population, such as what we see in Quebec. We have a number of patients with a specific disease called MPS IV. But when we take these ultra-rare disorders and we put them all together, they're relatively common. They affect about 1 in 7,000 individuals. The mucopolysaccharides are a subset, as I mentioned, of the lysosomal disorders, and they affect degradation of glycosaminoglycans. So what are glycosaminoglycans? We find them as basically the scaffolding, and we find them in the connective tissue of our body. So as you can imagine, if you have a problem in degrading or breaking down some of that connective tissue, or some of those glycosaminoglycans, we find these in basically every part of our body. So they're very multisystemic. What happens with the accumulation? We have a nice stream here. The water is going down and giving us wheat in the field. And this is happening by the breakdown of GAGs via an enzyme. If we have a block in this enzyme, as I mentioned before, we get accumulation of the glycosaminoglycans, which leads to flooding upstream. So that flooding upstream is a damage to the cell. The cells can lyse because of the enzymes that accumulate, the products that accumulate, causing damage specifically to the cell. But what we now know is those glycosaminoglycans are also bioactive, and they have downstream effects. So we can get mold downstream, or we can get disruption of the railways. meaning that this inflammation can cause problems elsewhere in the cell. And it's really by understanding that downstream process that we start to understand how these disorders work. I mentioned before that they were multisystemic disorders. One of the big effects of some of these disorders is accumulation of the glycosaminoglycans in the nervous system. If we have accumulation in the nervous system, we get a progressive impairment of development. We can also see problems in terms of clouding of the corneas in the eyes. The teeth are often malformed. The airways, they have restrictive lung disease, they have trouble breathing. The glycosaminoglycans are accumulating everywhere in the lungs, which can affect their mobility and sleep very severely. We can have problems with accumulation in the joints, problems in the way the bones are growing, and this affects mobility again. This is a young girl with Herner syndrome, and you can see the progressive nature of this disorder. I would say that this is a severe disorder in terms that she will have neurological involvement from the accumulation in the CNS. And you can see over a 3-year period, we've gone from the picture at 10 months to a coarsening of the facial features. And you can see this girl is already requiring oxygen to help her breathing. We can also have more attenuated disease. This is a man with Hunter syndrome, which is MPS II. And you can see as an adult, he has some of the same coarsening of the facial features. And although I say attenuated disease, I think this is not a mild disease. These patients will often have significant other involvement, maybe musculoskeletal or respiratory involvement. It significantly impinges on their life. So we're going to move to therapy now. When we talk about therapy, we can give therapy in many different ways. We can give symptom-based management, which might be something as simple as a hearing aid for the hearing loss that we see in this condition, or CPAP for the sleep apnea that we have. We can give support, as we've heard about tonight. It's very important that we're supporting the families and making sure that we're giving them the information, that we're providing psychological support to them as well. But I'm really going to focus on the disease-modifying therapies that exist for the MPS. And we've had good therapies for over 25 years. Not for all of them, but we have therapies for some of these mucopolysaccharidoses. And we're lucky in a way because we have a very specialized system for delivering the enzyme to the lysosomes. And that's basically a leader sequence. And you can see the woman up at the top bringing the group to the right place with her red flag there. The enzymes have a mannose 6-phosphate leader sequence that is put on in the nucleus, and it's actually then targeted directly to the lysosome by a mannose 6-phosphate receptor, which we find on the surface of the lysosome. If any enzyme escapes from the cell, it's picked up by receptors that are on the cell surface. So we can take advantage of this knowledge by giving enzyme intravenously. And if we give this enzyme intravenously, we know that it will get taken up by the cells and brought specifically to the lysosome, where it can act on degrading the glycosaminoglycans. This works better if we have better blood flow. So it works well in solid organs. It doesn't work as well in organs that don't have high blood flow, such as cornea of the eye or, let's say, the joints. So we have a partial effect of these enzyme replacement therapies. I liked what the last speaker was talking about when we were talking about measuring outcome. These are very, very complex, heterogeneous disorders. So there's quite a lot of variability from one individual to another. How somebody is impacted by their disease may not be measured as easily by the methods that we have. So often we do things like a 6-minute walk test, pulmonary function tests, cardiac tests, but really it's what the patients tell me that I listen to most and how it impacts on their day-to-day life. And sometimes we're not able to measure that as well, and we don't have the right tools for measuring it. But certainly we do see increased mobility. We can see better lung function, and we can see an increased quality of life in these patients. What we have, though, is a slowing of progression of the disease. It's not a cure at the moment. We can change the rapidity of progression, but it's clear that once-a-week administration is not ideal. I liken this to just doing your dishes once a week. You can pile them up, do everything, but by the end of the week, if you're walking around your kitchen, you're going to knock over some things and perhaps cause some damage. And really, we need better administration of that enzyme on a more regular basis. We can also have a problem with neutralizing antibodies. This, if you have a severe mutation and you've never seen that protein before, it's possible that after a while of exposure to the enzyme, that you'll start to make antibodies against the drug that's being used to treat you. And one of the big problems is as well, often we're trying to reverse damage that's already done. And this goes back to the diagnostic odyssey. Many of these patients have been from doctor to doctor to doctor before they get a diagnosis. And we're not actually starting the treatment early enough. Some of these disorders have been added to the newborn screening programs in certain jurisdictions. And I think that's going to help us get to the problems earlier in terms of treatment. But I think the biggest issue with peripheral enzyme replacement therapy is it does nothing to fix the neurological problems. So patients that have neurological involvement can get benefit. They can get decreased pain and increased mobility, but it doesn't change the course of the neurological progression. So it's clear we need more options. And I'm going to spend the last few minutes talking about some of the options that we can and some of the options that we're investigating. Transplants. Transplants have been used for over 20 years in some of these different disorders. MPS I is a very good example of this. What we're doing is we're giving hematopoietic stem cell transplants to the individuals, and those transplanted cells have enzyme-sufficient cells. So they will make enzymes, and because of the cross-correction that we talked about earlier, those cells will correct the deficient cells and break down the glycosaminoglycans. So why do we talk about this with the neurological impact? Well, with patients who have had stem cell transplant, some of the cells will eventually make their way up into the brain and start producing enzyme. They form microglial cells, and if the transplant is done early enough, before damage has occurred, these children do not end up having neurological progression. This works for MPS I very well. It's been well documented. It doesn't work very well for some of the other lysosomal storage disorders, and we don't really know why. So we need to try to understand that problem. We can bypass the blood-brain barrier by directly injecting enzyme into either the CSF or intraventricular regions. This will get rid of the storage material that's occurring in the CNS. But as I said, we have to be making sure we can provide a constant supply of enzyme. These techniques are currently done about once a month, and really I don't think it's enough to make a difference overall in the long run. They're currently in phase 2 and phase 3 trials for this particular technique. And finally, there's a company that's come up with an innovative way of trying to get the enzyme into the brain. And basically what they've done is take advantage of an existing pathway. So we know insulin binds to the human insulin receptor, and by receptor-mediated transcytosis, it crosses the blood-brain barrier. So some very intelligent people have designed a monoclonal antibody that is fused to the enzyme that we want to get into the brain. So this monoclonal antibody will basically take the hitchhiker, bring them across into the brain, and that hitchhiker is the enzyme. The enzyme will then bind to the mannose-6-phosphate receptor, be taken up into the neural cells, and break down the glycosaminoglycans that have accumulated there. So this is early on in development, but it's a promising possibility for treatment. And these are just some of the disorders that are in phase 1, phase 2 trials. So we talked about gene editing, and this is a company called Sangamo Therapeutics who is using this zinc finger gene editing. It's currently in phase 2 trials. We don't know if it's going to work, but they've done about 6 patients to date, and we're expecting to hear from the outcomes very shortly. And finally, I'll talk about gene therapy. So gene therapy, we mentioned earlier this evening with adeno-associated viruses. And this is really a hotspot of research right now. When I looked up yesterday on clinicaltrials.gov, we can see that there's 57 studies for gene therapy just for lysosomal storage disorders. This is a very rare group of disorders. We were talking about 1 in 100,000 individuals, or 1 in 8,000 when we combine all the lysosomal storages together. But we have 57 trials that are undergoing for this. So I think this is an exciting time for lysosomal storage disorders, and if we can get the experience with this particular group of disorders, we can translate this knowledge to other inborn errors of metabolism. I think we can be cautiously optimistic about treatments for this particular disorder. We're very early in trials. We don't know what are going to be the long-term effects, but we have to watch and wait and follow these patients. There's a problem of immunity, either to the vector itself. So if we've already been exposed to adeno-associated virus number 8, and we're trying to give that as a gene therapy, our body's just going to destroy the virus before the payload is delivered. And again, we might have a problem for those more severe patients who've never seen the protein before. They might have an immune reaction to that as well. But we are in exciting times right now. We are currently starting our first gene therapy trial, and we should be recruiting our patient next month. That's what we hope, if everything goes well and they're not immune to the viral vector. And we've got more trials starting later this year. And one of the trials that I wanted to talk about was actually the result of a parent who went and said, I need to do something about the lack of treatment for my child. They formed a network of other parents. They raised a lot of money, and they were able to fund a researcher, part of the work that this researcher was doing for a gene therapy trial. And this is currently in phase 2 trials, and we're expecting it to move to phase 3 later this year. So I'd like to finish there. I'd like to thank the people in my clinical team and my lab, and the funders that have made some of my work possible, and also, of course, my patients. So thank you very much.